I'd like to ask both Dr. Kapoor and Linda to come back up to the microphone and entertain questions from the audience.
That's an excellent question, and just for the sake of the presentation, I didn't go into all that, but very often we do take the kidney out in stage 4 cancer, and that's a whole separate lecture in itself. But basically, we know that if you can take out the tumor in stage 4 cancer, you may increase the success of drug therapy afterwards. So if you have two patients, one where the tumor is in place, one where the tumor is taken out in stage 4 cancer, that patient who has this tumor taken out, if it's possible to take it out, that patient may respond better to Sutent or interleukin or whatever afterwards. Now, having said that, we have to keep in mind that taking that tumor out is not a cure anymore, because it's stage 4, and so there's spots everywhere. So the way I like to give an analogy for it is that the kidney at that point is just one spot of many spots of cancer. So you have your spot in your kidney, you have a spot in your lungs or your liver or wherever else, and so that's just one spot. Ideally, if we could take out all those spots, all the spots in the lungs, all those spots in the liver and the kidney, that would potentially be the best cure, but then you'd have no organs left. So that's why we don't always take out that kidney. And so if the kidney is gone into the vein or really advanced or really, really huge, then we have to decide and make the decision together about what to do. Because it may not be the best thing to make a big incision to take out that big tumor and have your recovery 6 to 8 weeks from that big incision when you have other spots of cancer already there. So it's an individualized decision with the patient. Usually if the cancer reoccurs later, it's tend to be slower growing, but the treatment is still the same. So for example, we had a young fella who was 80 who had their kidney out 20 years prior, and then had an area where the kidney used to be, and it had grown slowly to encompass the spleen. So that cancer was there 20 years prior, and it just had grown slowly over 20 years. So ideally what you could do is if you could remove that entire area, that would potentially re-cure him, but it wasn't feasible. So in that phase, we put him back on the same drugs that we would if he had occurred on any other patient. So the short answer is it's the exact same treatment, but it tends to be slower growing if it happens later. Our standard of care for stage 1, 2, and 3 cancer is to stop follow-up after 5 years. So the guidelines in Canada and the States are if you've had your cancer removed, is to, we do a CT scan or ultrasound every 6 months or so for 5 years. Then we call it a day and say go home and have a beer. But I suggest to my patients that they should have an abdominal ultrasound probably every 5 years for life. There's no radiation exposure and it's a pretty harmless test, just for those rarities where it may be somewhere else. Well, come to Ontario, we'll put you in right away. So, so the committee in Ontario is me and Dr. Hutt and Dr. Mukherjee, and we'll make a decision at the same day. So I've never actually heard of an efficacy committee. I can't even say it right. So I don't know how long they take, but I would say they should make it right away. You tell them I said make it right away. So that's an excellent question. So that leads into an area of my interest, which is pre-surgical therapy. So I'm not sure if there's anybody in the room, but there's some patients that have come through that have had big kidney cancers, and they have local nodes, and we put them on drug therapy to shrink down the nodes, and then taking their tumors out afterwards. And it's been a very successful trial, and so we're excited about that. So along those lines, in your case, or this case, where if you're on a drug for a period of time and everything shrinks down, we would do surgery on that if it's feasible. So again, it all depends upon practicality. It's actually only as complicated as the number of sites, so number of areas of cancer. So if somebody comes in with a kidney cancer and there's a spot in the lung, one spot in the lung, what we'll advocate is that you should have the kidney cancer out and the spot in the lung out. The survival is very high with that, much better than any drug therapy. Even if somebody comes in with the kidney cancer and 2 spots in the lung, we'll take both of those out. And your survival rate's much better than any drug therapy. Somebody has kidney cancer spread to an area of bone, we'll actually remove a piece of the bone, and your cure rate's high. So when do you stop? If you have a spot in your lung, in your liver, in your bone, and in the kidney, we can't take out all those parts. It's just not feasible to have all those body parts removed. So it really depends, again, an individualized, personalized basis, how many spots there are. But the best option for somebody who has metastatic disease is to try and remove it if practical. Yeah, after you have a CAT scan, you discuss it with your medical oncologist and you say, can we take it out?
Well, we know from the literature and from the from the research that indeed that's the case, that there has been research that indicates that prior to the test and until the actual results, that you can actually draw a graph that goes up and goes fairly high and then drops down immediately. So I guess there are no easy answers except do all the things, do one activity every day in different parts of your life. I don't think there's an easy answer for that. I think each unique person will come up with their own strategy of coping with the anxiety. We cannot say that you're going to reduce the anxiety. That would be giving you false information. The anxiety is there, it's going to be there. You have to recognize what the trigger is. Many people are very worried. They don't have a real sense of why they're so anxious. So they'll just say, oh my gosh, I'm having anxiety attacks, I'm not sleeping, things are terrible, I'm having nightmares, I'm falling apart, I don't know what's wrong. So you need to recognize what the trigger is. You recognize that, yes, you've had a CT scan and you've had some test results that are pending, and that's what's causing the anxiety. It's not that you're falling apart. It's not that you're depressed. It's not that you're going crazy. There is a reason for it. So at that point in time, once you've identified what the problem is, then you start increasing some of your coping strategies. So some of the strategies that I've talked about. Maybe increase your exercise, or maybe increase the amount of times that you do journaling. Maybe increase your meditation. Maybe you see friends or family more often. The things that you don't do are you don't drink more heavily, or you don't smoke more heavily, or you don't do any of, you don't start, eating more heavily. That's just too bad, isn't it? So that you don't do those kinds of things, but you really start to do things that might reduce your anxiety, and for every person that would be different. But you start looking at, okay, what are some strategies that I already use to deal with my anxiety, and increase those until you feel that your anxiety is back under control again. I mean, you may need to see a professional counselor during those periods of time, and you can actually sort of book ahead. So if you get a counselor, your family doctor, for example, you could book ahead. Every time you know a CT scan is coming, you book an appointment. So there are different ways of dealing with it, but first of all, you need to recognize what it is, and that it's perfectly acceptable, perfectly normal for an abnormal situation. Absolutely. Yep, absolutely. Yep. And all your friends and your whole circle. Yep. So the one thing that you can perhaps do as a caregiver and for your circle of friends is protect the patient a little bit. So one of the complaints that we hear is that people will call up and say, so did you get the results yet? What did the results say? Did you see the doctor today? And then on the day of the doctor's appointment, you have 10 people calling, or you have lots of emails or lots of messages. What did the doctor say? What's going to be recommended? So one of the strategies for that situation is to actually have a key person that notifies, or you do a bulk email, or you have something on your answering machine that protects you and the patient from all of those results once your anxiety period's over. Yeah, absolutely.
You'd have to have a Quebec OHIP card or Quebec health card. So congratulations that you're fine. That's great to see. You're only 18. That's great. I have a son who's 16. Anyway, sorry. But what I would do if you were my daughter is get an ultrasound probably every 5 years for life. Yeah, for life. I think that's reasonable. I mean, the other I've never met you before, but we have a genetic counselor on board, Dr. Zubak, here at the Cancer Center. You might want to consider having some genetic testing as well. You did all this stuff. Okay, excellent. So yeah, just have a lifelong ultrasound. It's no radiation and gives you some peace of mind. So. Yeah.
What about chest X-ray?
So that's a good question. I've thought about that. So what I've been doing is doing a ultrasound and chest X-ray on those patients beyond 5 years, every 5 years. But I'm moving away from the chest X-ray because I think that if you do have a recurrence 10, 15 years down the road, it's going to be local. But that's not evidence-based. So doing a chest X-ray is also very minimal radiation. But at your age, I would stay away from too many CT scans because that's not good for you at 18.